slide.
Yeah.
And then if
Look,
I'll go forward and see whether, yeah, it's going now.
correct. Fine.
Okay, fine. Okay, fine. Okay,
Thank you.
so I'm so sorry about that. Some technical hitch. So we are going to talk about extra canal pathology. All of us at some point during our radiology career will be looking at MR lumbar spine. So I thought it's a very important topic, and it is our bread and butter, reporting MR lumbar spines. So we should be aware of what we can, sometimes miss. So we will discuss the extracanal pathology working from anterior to posterior. And we'll share some tips, of how the review areas works. So I would like to thank Nick, who was my reg when we started looking at this kind of things, what can be missed and things like that. And now he's a consultant in Truro. So he's done a lot of work, on this. So first case, MRI lumbar spine, the history is fall onto coccyx, incontinent of bladder and bowel for 4 days. Yeah, and then saddle symptoms, but no weak legs. And the history was, the query was cauda equina syndrome. So all these cases will be a lot interactive. So I would request everybody to please, start wear your thinking hats. And as we go through, the image, please think of the diagnosis, and you can start putting in the chat as well, so that it's more interactive and you're in the thinking seat rather than just listening mode. Yeah. So this is the MR. Okay. I didn't put in the backspin. Maybe next time we can have, dynamic images on the backspin that you can have a look before we do the session. But the answer is on these slides. Okay. So I'm just going to give you about 10 seconds to have a look and make up your mind. Okay, fine. So the history, the initial report that went out was degenerative changes, mild as detailed above, but no compression on the cauda equina. It's true, isn't it? I mean, if you go back and look, there's no cauda equina, and there are some degenerative changes because there's a small, disc bulge there, some hypertrophy of the facet joints or degenerative changes of the facet joints. So mild changes are there. Okay. But then it's not completely correct. And should there be addendum, or what is the main finding? What do you think? So that's why I said thinking hats on. So go look at it. So Nick has actually, painted it up so that we can see what is happening. So normally, if you think about it, you should not have, a big wad of tissue in front of the spine. Okay, because you have the IVC and the aorta, and then you have the fat around it. But here you can see it's soft tissue density. Okay, and usually at this point, if it's in the on the slightly to the left of the midline, you should be able to see the aorta. Okay, so you can't see, it looks as if it's no tubular structure is there. And that is because there is a mass that you can see. So I can convince you to see now, I know there's a saturation band, and that's what makes it more difficult to find these things and report them. But when you look back, it is there. It's definitely there. So, and the reason that the patient is having, symptoms or pain, maybe because of, this other symptoms that other findings that we have in the like in this patient. So the IVC and aorta are not visible, and the aorta, on the parasagittal, like I said, you should have some tubular structure, but you can't see it. And it's actually lifted off a little bit because of the lymphadenopathy. So aorta is lifted off, and the patient went on to have a CT scan because you need to look, what is the extent of lymphadenopathy, how much is there, and what is the diagnosis, in this case. So the main findings, as you can see, this is what you were looking on the MR scan. This is what you were seeing. The saturation band was there, and this is still here is what you were looking. So instead of the aorta sitting there, you had, a wedge of soft tissue in front of the vertebral body. So, like I said, the pathology is covered by the saturation band. It's relatively symmetrical structure. You always will not miss if there is no change in the shape of the structure. Yeah. If suddenly the scapula is missing, if nothing changes, you will not see or notice that. Okay. If suddenly the patella is, taken off, the knee joint, if you do not register, there should be three bones, on the lateral view. Where's the patella in the front? Then only it will distinguish. Otherwise, the shape doesn't change. So if it doesn't change and it's all symmetrical, it looks, because the brain has registered how it should look in this region, then it's very difficult to find that, or note that finding. And you may be biased by the history because that was pointing to cauda equina. So your focus is all around here, within the canal and the nerve roots and the exiting nerve roots and the transiting nerve roots. All the focus is on here. So it is easy, to miss something that is not in the focus area, not pointing towards the history, and also the interpretation is difficult because of the saturation band. So make a mental note. When I am reporting, yes, I go look at the canal. I'll go look at, the main answer is like, is there a disc? Is there something causing nerve root compression? Yes, that's what, the test is done mainly for. But then zoom out and then look at other structures, and do not miss, the anterior structures. Do not miss as you come down, sacral insufficiency fractures and things like that. So that's the approach I have. Okay, answer the question first, go look at the corners, make sure that you're not missed any a lesion in the end of the spinal cord that you can see, and within the spinal cord, or within the spinal canal. Do all that, but then, zoom out and look at all the surrounding structures. So, case number 2. This patient has previous L4 fracture, 4 months of worsening low back pain with cramps bilaterally, worse on the right, and pain is worse on walking. Okay. This one, I got a call from the radiographer saying, can you please review the images? And we said, okay, fine. So, and it was done at a remote center as well. It wasn't, the patient was not in the main hospital site. So we looked at the images, and I immediately did after that something. So I want you to now look at the images. Whatever images I'm showing you, the answer is on the images. Okay, so there's nothing, we are not hiding anything. The answer is on the image. So have a look. And again, I'll give you 10 seconds. I'm sure while reporting, you'll get more than that. Okay, fine. So I'm sure many of you would have noticed the pathology, immediately. And this is highlighting it so that, there's no doubt about, where the pathology is. So it's within the aorta. And I just want you to note, on the previous one, we were trying to say that there should be fat, you should be able to see the aorta and the IVC. So this is a good example. I didn't put normal next to the abnormal on the previous case because it looks like, oh, really? Can you actually see it? And this is an example to show you that, yes, you should be able to see fat, anterior to the vertebral body, and you should be able to see the IVC and aorta. Okay. So this is a case where, you can see high signal intensity. So this is a T2 weighted image, T2 weighted image on this one as well. And on the T1, it wasn't very contributory, but what should you not have? Because it should have signal void, isn't it, all the way through. Go back, it's white. The iota is white. Why is the iota white? It's because it's occluded. Okay, so high T2, indeterminate, T1. So T1 wasn't very helpful. That's why I have not included it on this a series of images that I'm showing you. So it's a well-defined region in the inferior, portion of the aorta. It lacks the normal flow void. So that's what. So again, now you have to think about, okay, not only do I need to see aorta, I need to see black, you know, uh, holes there. Okay, so I need to see IVC, I need to see aorta, but I need to see them as flow voids. So, and if you think about the history, so let's go back to the history. So it said 4 months worsening pain, cramps, bilaterally worse, okay, and worse on walking, okay. So all this looks as if it could be neurogenic, but think about it. All that history can explain vascular claudication. Okay, so though the history is actually right, I mean, the patient's symptoms are actually right, but we were looking at the wrong tree. Like we were looking at neural causes of the pain, but it was actually vascular cause for the pain. So I'm showing you the T1. Like I said, it's not as spectacular as the T2. On the T2, you can very clearly see it. Okay. On T1, you can just about see that there is a lack of flow void, but it's more difficult to see on that. And so what I did, the patient was there with the radiographer. So I said, no, I'll send the patient to Derriford, like, that's the main hospital. And I also called the vascular team. And I said, see, this patient is coming in. He had claudication. I don't know the extent because that's all I can see on the MR scan. I'm going to arrange a urgent iodogram, but the patient will need a clinical assessment. So can you please see the patient? And then he had this scan, and you can see that the patient has a really large thrombus, and it is kind of subacute because if you go to the thing, then there is some, flow that you can see distally. So he has, recanalized some of it, but it's a really large, thrombus. Okay. So the patient was then, taken by the vascular team, and the right things, the right management was offered. So you see, MSK radiologists can save lives because it's like what I mean, how do you? Most of it is like fractures or tumors or masses. No, but you can have other things as well. And this is a typical example. And hats off to the radiographer because they thought something is wrong. They were not like very sure, but they said I mean, it's not like the normal that we see, so we just want to you to have a look. So very well done and well spotted. And as I said, like the previous case, check aorta, IVC, but also check whether it has the flow void. Okay. And T1, like I said, easy to miss. And just to reiterate, again, T1, it was easy to miss. You can just about see it. But T2, look, you can see it very nicely. Okay. So look for flow void and look to see whether the IVC and the aorta are both there. And of course, do the needful. We are clinical radiologists, so the needful, especially if the patient is symptomatic, will be to go on and arrange the correct test that will answer the question. Next one, fall, lumbar back pain, proximal leg weakness, and the patient is now using wheelchair. Okay. So they have done a myeloma screen, and that was negative. And but it's quite some red flag signs because he's now using a wheelchair. So I again want you to look, and I have labeled the images. So T1, you can see the bladder is completely black, and T2, it's showing you, CSF, and the bladder has fluid. And again, 10 seconds. Okay, I think some answers are coming up. I can't see all the responses, uh, but it's good to see that people are engaging. So good. Okay. So I'm sure you have noticed this, and again, Nick has done this effects So the disc is higher signal than vertebral bodies. Yeah, and this is diffuse metastatic disease. Okay, so this is important. So again, there is no change in the vertebral body heights. There's no change in the shape. Okay, all there is change is in the signal intensity. So again, it's like the more you report, the better you get at spotting these, changes. And I think we have a normal, if I am right. Let me see. No, I think we have another slide which shows normal. So normally, the vertebral body on T1 weighted images should be lower than, I mean, the disc should be lower than the vertebral body. Why? Because the vertebral body has a little bit fat, and on T1, it will be higher signal. Okay, and the disc, even it's dehydrated, should have some fluid. Okay, so that should be the relation on T1 weighted images for the disc and the vertebral bodies. But here you can see the disc is much brighter than the vertebral body, which is completely wrong. Okay, and that's the only clue actually. I have had this at least 3 times. And Plymouth, we have a lot of marine population as well here, because it's a base, naval base. Yeah. So I had once a very young patient complaining of back pain, and we fast track them because they go, they can be deployed, and they have exercise regimes they have to complete and things like that. And it was nothing else was there. There was just diffuse infiltration of the vertebral bodies, and that was evident only on T1, and that was lymphoma in that patient, younger patient. Okay, so this is a older female patient, and it's diffuse metastatic disease, and the patient is known to have breast cancer, which they hadn't given in the first instance. Okay, and this is again about adults should have fatty marrow in the vertebral bodies. Okay, and this is again very important about what signal intensity should marrow have. As we age, the central axial skeleton will have a little bit more red marrow compared to the rest of the appendicular skeleton. But it will still have more fatty marrow as we age. So it should not become darker as we age. What are the exceptions? Exceptions is in smokers, or if people are doing, training for marathons or training for doing a lot of exercise, and or if they have menorrhagia or anemia of some kind, then their marrow reconversion happens. That means the fatty marrow that is normally present in adults will become red marrow because there's a need for the body to have more red marrow. Okay. Whereas younger adults, they should have more red marrow in the vertebral bodies. Yeah. So that's why in that young patient, in a younger patient, it was more difficult to actually recognize that reversal of the signal intensity on the T1. But you have to be really astute and really observant about this, because you will be the first clinician to give the diagnosis. That is why it's important. Okay, and you have to do good by the patient. So you will be the first one to actually spot the abnormality. So learning point, the new and yeah, that's the other thing. I mean, those who are working in UK will know that the new Kodak protocol, it does not have a T1 included in it. So it's more difficult to pick up these changes on T2, because T2 already has a little bit of fatty marrow. It will already have high signal due to the meds itself. So it is high signal due to fat, high signal due to meds. So it will not be as clear if you have diffuse infiltration on the T2. Whereas T1, it's very clear because it should not have as much water and it should have more fatty marrow. Okay. So another example, so this patient is actually, myeloma patient, and you can also see, there is loss of vertebral body height here and a slight retropulsion here. So this is more diffuse, and you can see there's some soft tissue components to it, unlike, the other one where there was no soft tissue component to it. Yes, so this is the slide I was telling you about. So just to remind yourself, yeah, this is what normal should look like. So normally the disc should be lower, the vertebral body marrow should be slightly higher because of the fat content on T1. This is patchy infiltration. If it's like this, it's easy to make out because it's not uniform. So the brain will immediately pick it up. Yeah. Whereas if it's again uniform like this, then if you do not note the reversal, it will not be any different. So that's why it's very important to bear this relation of the vertebral body with the disc base height. Okay, fine. And I think we did one paper on bone marrow reconversion and the um, in patients with extreme cachexia, they can have serous atrophy of the bone marrow. It's called SABM, serous atrophy of bone marrow. So I think those bone marrow changes are very important, and the reconversion and spotting that, and also the fact that how diffuse infiltration will present is important. So this can be anywhere. It can be a scan of the shoulder, or it can be of the pelvis. Yeah, so this will apply to any MR, any body part. Okay, moving on to the next case. Right leg sciatica without back pain, but numbness in the buttock. So that's the history. So we will review images 2019, 2022, okay, and then we'll review the MRI in that order. So MRI in 2019, there is a low signal. You can see here. Okay. In 2022, it's all speckled. So again, 10 seconds, I want you to think about the differential diagnosis. We already given one, like meds were suspected, but think about other things that can cause such appearance. I can again see some. Okay, fine. So again, Nick is very good at annotating. So he's annotated it to show, the speckled appearance. If you really mag it, you can see actually a very good speckled appearance of the bone marrow. Yeah. So in this case, the diagnosis was sarcoidosis. Okay. So though, yes, history was as if it could be something to do with a nerve root compression of maybe L5, S1, and into the buttocks, so higher up, L2, L3. But think about, what is the changes that are happening in the lumbar vertebral bodies. So we are still in the marrow thing. So we have gone into the vertebral bodies and we are still the vertebral body level. And the changes that can happen can be not only secondary to metastatic deposits, but sarcoidosis. Sarcoidosis, it's like one of the greatest mimic. If we think about sarcoidosis here, we think about TB in the endemic places. So they are greatest mimic of many conditions. So if you think about something that is disappearing with steroids, or it's self-limiting, and it looks like meds, but it's not meds because it's not progressing, then think of sarcoidosis. So this is the appearances here. So this is a clear example. This is what I meant. So you see there is improvement after treatment with steroids. So the vertebral body changes have improved and the lung changes have improved. Okay, so it is having series of images, and it's good to see and follow it up, and then understand that sarcoidosis, it can do things and mimic meds and inflammatory conditions and things like that. Okay, so sarcoidosis, please remember sarcoidosis. Okay, next case. So review 2-week wait referral. Yeah. So 2-week wait, if you're working in UK, you will know it's a cancer pathway. And those who are preparing, for the exams, if they say that, that means it's like accelerated pathway. So the patient is getting, should be seen within 2 weeks to have the kind of imaging or clinical review, and should have the diagnosis also accelerated. Okay. So that means, and also it means that, the clinician who's sending the patient is worried about the patient. So there are red flag signs. Yeah. So this is the, we changed tack now. So from MR, we are moving to CT, but still we are in, the spine thing. We'll keep the spine theme. So this was the initial report. There's significant ankylosis, which change is consistent with ankylosing spondylitis, and it's also affecting the lumbar spine. So I want you to again look at the images, and I want you to review them with all the information that you have. So you have the same information that the reporter would have had, and that is it's a 2-week wait referral, night sweats, malaise, aches, and pains. Okay, and they're looking for cancer. Okay, and again, these are relevant images. They will have the answer on them. So please uh, think about it and share whether you agree with the report that was suggested, or are there any additional findings that you are seeing and you would like to talk about on the CT, so, or would like to include that in your report. So again, 10 seconds. Okay, so again, I can see some interaction. I'm not able to read all the chat answers because I don't want to change the IT. I don't want to, try and look at the chat. So I can see there's interaction. So let's move forward. Okay, so that was the initial thing, but the sacral leg joints are normal. Yeah. So because the patient had a CT tap, like so, from the chest, abdomen, pelvis was included. So sacroiliac joints are normal. So how many of you did notice that again, next to the spine is the aorta, and it has, typical thickening. So if I go back to the sagittal images that you had, okay, so this is the image I gave you. Yeah, you can see very nicely. Good going thickening. Okay, good going thickening. Yeah, and So this is, slightly to the right of the spine, and that is typical for DISH. This is diffuse idiopathic skeletal hypotrosis. So there are two things I want you to take home from this case. One is the diagnosis of DISH, because yes, ankylosing spondylitis, you can say that that is spondyloarthropathy, and that may explain aches and pains and generalized, malaise and tiredness. Okay, so that's why it comes into play, because the rheumatologists sometimes get referrals like that. But the other referral, the other diagnosis that is more important, is the vasculitis. That needs to be treated immediately, okay? And this is not ankylosing spondylitis, because the sacroiliac joints, yes, there are some cases where you can have absolutely no sacroiliac joint changes. But if you look at, the distribution of the changes, it's typical of DISH and not ankylosing spondylitis, okay? And that's the one that is causing the patient symptoms in this case. So further review of the vasculature. So if you look, the axial scans, look at that. It's left subclavian artery, and we looked at the arch of aorta, and that's what you're seeing on the sagittal images, okay? And then the descending aorta as well. Okay, so there's definite thickening, and then the patient went on to have a PET CT, and which again confirms the diagnosis of vasculitis, and was treated with steroids by the rheumatologist and felt much better. So again, it's the radiologist who's making the first diagnosis of this condition in this patient. Okay, and this is post-treatment. So this is there, and this is after treatment. So you cured the patient as well. Okay, so very positive results of good diagnostic skills and leading to good management of the patient and good result or good outcome for the patient. Okay, so I always think, radiologists, we are like detectives. Okay, we are given this much information, but then we can make out much more, from that small. So what did we have in this case? We had one liner, right? We had one liner: night sweats, malaise, aches and pains. So think about, all this, especially the malaise, aches and pains, the vasculitis can easily explain that. Okay. So whenever you have now onwards cancer search, please do look, anterior to the spine at the aorta and see whether there's vasculitis or not. Okay, the second thing I wanted to focus on in this case is about the differential of the syndesmophytes or fusion of the spine. And so one of the main things is ankylosing spondylitis, but it's both anterior and posterior longitudinal ligaments, and it's thin calcifications, and you get this bamboo spine appearance. Okay, that's the bamboo spine appearance, and yeah, it was thought to start in the lumbar and sacral spine, but we know it starts in the thoracic spine, and then it goes to the posterior elements as well. So you have these interspinous ligaments or the costotransverse joints also involved, and then it can have sacroiliac joint changes, and then it can go into the lumbar spine, and also very infrequently into the C-spine. Okay, then you have the DISH, which is the prominent flowing anterior osteophytes, and it's more common in the lower thoracic, and it's usually on the left. For some reason, they say the aortic pulsation, it does not allow that kind of anterior osteophytes to be seen on the left side of the spine. Okay, and the last one is what we call the posterior longitudinal ligament calcification. So ossification of the posterior longitudinal ligament, OPLL. Okay, and it's thick linear sheet of ossification, and it is usually in the cervical and the thoracic spine, and it's yes, it can be associated with degenerative changes, but I just wanted you to just have the three things side by side and you can, dissect, and then you can take it into your brain library to say, these are the changes that I'm looking for. Okay. But the main learning point in this case is please review the large vessels. Don't forget, the aorta in front of the spine. Okay, so the next one, case 6. So this one is fall on slate, infected wound, retained foreign body. Yeah. So just because, the static images, again, Nick has highlighted that is the pathology. Okay. So again, 10 seconds, and I want you to think about, what pathology what differential will you give? That's all is the history. I mean, that's the history that, the reporter had as well. Yeah. And it's not trying to misguide anybody. That's the history that came with the patient. Yeah. So I just want you to think about the differential. That's not the main, that will not be the final diagnosis. What do you want to think about? Okay, so I can see some um, responses coming in. Good. Okay, so we'll move to this. So on the MR and the CT, it is same, like it hasn't added much, isn't it? It is a sclerotic lesion. It confirms that it's a sclerotic lesion because it's low signal intensity on T1, and it, increased sclerosis on the CT as well. Yeah, so it is just confirmed that there are sclerotic lesions in the tibia and in the fibula as well, but I'm not showing you the slides for the fibula. Okay, fine. So next one, the bone scan. It shows um, this is like osteoblastic, yeah, response, and it shows further changes in the lumbar and thoracic spine. So that's where, the spinal bit comes in. Okay. So it was the other way. So we started with the spine, but I'm putting it, in this and saying that these were the changes that you may want to look back at the packet. Okay. So this is the MR scan that, the patient presented. So subsequent MRI around 5 years later, progression of the T1 foci of low signal intensity. So if we take these, yeah, these are like for like. So in 5, if you see, this is the later one, this is the earlier one. So some of them have disappeared. Yeah. In this one, it looks as if, oh, that's clearer. Yeah. But if you see in this vertebra, there's new lesion. This one appears, okay, maybe not very, it's not there anymore because it was here. Okay. So that's that disc there. So it is as if some have come and some have gone. Okay. So if it's meds, it's not going to do that unless the patient is on treatment, of course. Yeah. So his patient has not been on treatment for meds. Okay. And so some lesions have disappeared. But remember, the hallmark of these lesions is they are sclerotic. Okay. Different degrees, but they are sclerotic. They're low on T1. So that is the one of the main characteristic features of this. Okay. So if you see here, I mean, again, T1 is slightly better if you want to see the changes because fat is there and fat is like, whitish, and then you get the changes. So you can see the changes here as well. So it's easier to see on T1, whereas on STIR, it's not very impressive, isn't it? It's like nearly normal. What is all the fuss about? Yeah. So it's not well this one. So one of the teaching points is please, don't forget the T1. Please have the T1 and have review it. Okay. So what is the diagnosis? So this was CRMO, chronic recurrent multifocal osteomyelitis. Okay. So this Nick put in because he said, Dr. Suresh, you're the one who always, shows us 1 or 2 clay cases. They don't come very often. Yeah, because it is rare. It's one in, so many thousands. Yeah. So, but I have at least seen 3 index cases. That means in I think now coming to nearly 20 years of being a consultant, I have seen 3 where you make the diagnosis, like the first diagnosis you make. Yeah. So it is rare, but it's very important diagnosis when you make it. Um, and 3 in the sense like, first time presentation. Others were like, oh, they were called something else, or they were this one. And then you come in and say, oh no, I think it is CRMO because of this. Yeah. So the more cases that you see, because I think because being MSK and, we are looking for these cases, so we have a little bit more. So when I was doing my fellowship in Stanmore, I did a paper with Dr. Saifuddin, and many of you, may be aware of his papers. He's published loads. So we did one on the clavicle and, the clavicular lesions, and CRMO is one thing that, you can see in the clavicle. And I think that's what makes me a little bit more confident in diagnosing this condition. So it's mostly seen in females, and it's chronic multifocal bone pain. It can be associated in adults with, a condition called SAPHO, and no definite infected cause. So if you go biopsy it, the pathologist will ask you, like, what do you think it is? Like, because there'll not be anything much on it. They'll say, did you get the sample actually? You try to grow bugs from it, you will not get anything. It will not grow anything. So commonest site is the clavicle, and it'll have uh, it'll have periosteal reaction, but it'll be consolidated periosteal reaction that you will see. Okay, and that low signal on the T1, that's very, very typical in when you are looking for CRMO. Okay, so going back to the spine, please think about, we thought about sarcoidosis, remember, in the other case. So think about why it's fluctuating, why it's changing. And uh, because if you biopsy, like I said, if you biopsy, pathologists will just turn around and say, did you actually get the lesion? Because there'll not be much changes. They'll be like, there's no cancer, definitely, and it's not growing anything. And yes, there are some marrow changes, but it's not, they can't just say, oh yeah, that is CRMO. Whereas if you say, I think it's CRMO, what do you think on the pathology? They'll say, yeah, that, the appearance is in keeping with that. Okay. So that is CRMO. So we have done 2 slightly rarer, entities in bone, sclerotic lesion in the bones presentation. That's one is sarcoidosis and one is CRMO. Okay, moving on to case 7. We're nearly there. Don't worry. So known carcinoma of the cervix, pain in the lower back, query, meds. Okay, that's the history that we were given. And this sometimes you find in the sagittal, parasagittal images of the spine. Okay, in the last parasagittal image, you may find, high signal intensity. Yeah. So I am sure this is too easy for you guys. So please type in the answers. What do you think this is? So you had the history, carcinoma cervix. So I'll go back to history again. Yeah. So known carcinoma cervix, pain in the lower back. Okay, fine. So this is, what you call the Honda sign. It's Honda sign is more in the nuclear medicine, but on the MR, it looks like a Honda, right? It looks like that. So it's insufficiency fractures. And again, definition of insufficiency fractures is normal stress on abnormal bone. So the bone is abnormal because of the history. I gave you history of carcinoma cervix. So patient has had some radiotherapy, and therefore, there are radiotherapy changes in the bone, and therefore it is abnormal and can fracture easily. So that's insufficiency fractures. In this case, post radiotherapy changes inducing that. Or it can be like osteoporosis, or patients on on steroids in rheumatoid arthritis, Paget's disease. The bone changes and you can get fractures, incremental fractures. osteomalacia, vitamin D deficiency, or in diabetics, again, neuropathy causes, bone loss, and therefore that can subject to fractures. And in this case, like I said, radiotherapy. So again, this is important because the treatment is bisphosphonates and bone protection rather than anything, to do with the tumor. So usually gynecologists, ask us to report these to ensure that there's no mets causing the pain. Okay, fine. So I think we are nearly, okay, case 8. Okay, so unusual high signal within the spinous process. This is in the posterior aspect, yeah? So this is on the PET scan. So you can see we have worked our way through this, and then, we are right at the back. So we are nearly on the last but one case, I think. So high uptake on the PET at multiple levels. Okay. And this patient is known to have, I think, colonic cancer or something, and that's why they had the PET CT. Yeah. So, but I mean, are these normal locations for metastatic deposits? So you'll have to think, is this really, metastatic deposits? Because that's what it was kind of reported. So this was raised as unusual, but metastatic cannot be excluded. I know that's what it was reported as. Not helpful because the team wants to know whether to treat and how to treat, because it depends on, the staging for the patient. So then we looked at, the CT scan for this patient because they had the staging CT. And on that, you can see there are cystic changes within the spinous processes. There's hypertrophy of the spinous processes and some nodularity, that you can see. So these are, so this is again, thanks to Nick for, showing what normal spinous processes should look like, and this is the abnormal or enlarged spinal processes with minimal changes between them. Okay, so again, he's illustrated it very elegantly by showing, okay, that's what the normal should look like, and this is the, in this patient, in this case, how it looks. And do you know what the diagnosis for this one is? So again, I'll just give you 5 seconds this time, because we are running out of time. I don't want to delay Dr. Khan. So what do you think is the diagnosis in this case? So this is what we call Bastrop's disease, yeah, or the kissing spinous processes. And it causes flattening, sclerosis, enlargement, cystic changes, and there's interspinous bursitis. All that is causing the high signal inflammatory changes, between the spinous processes. And that's what you were seeing on the PET CT scan. Okay, so the more you report, the more you see this. And some of it can be really dramatic, with really big subchondral cystic changes and sclerosis. So be careful calling it METs, calling the changes something else. And that may be the cause for changes rather than looking at the spinal cord itself. So again, it's extra canal that the changes are. So just a few words. Bastrop's disease, like he's the man who, described it. And when significant changes develop, this can result in bursa, and that's what causes that, neural. But the important thing, one important thing, I have not seen a case myself of this, but it has been reported in literature that it can extend, into the epidural, or it can form like an epidural fibrotic mass narrowing the canal. So we have, you can see it going, so if you look at this, you can see it going this way, but it can go this way as well into the canal. Yeah. Okay, fine. So last case. So this is very new. So a 25-year-old thoracic and pain, query disc, query radicular. Again, look at the case. And you can see, there's some focal mass that you can see, and it's nearly now out. We are past the spinous process also into the subcutaneous tissue now. Okay, and this is causing, thoracic pain for this patient. And this was a case of desmoplastic fibroma. Okay, rare diagnosis, but it is just a case to illustrate. Please look for extraspinal pathology that is causing pain in younger patients. If the canal looks fine, it looks no see it looks beautiful. That there's no canal pathology. There's nothing in the spinal cord itself. There are no discs. They all look fine. So what is the pathology? Please look for other causes outside the spinal canal. And this, I mean, it can be very infiltrative, locally, aggressive. Though it's a benign lesion, it can be locally aggressive, and it can have recurrence as well. So it is treated, in sarcoma centers because of the local aggressive nature of the lesion. Okay, fine. So what we have done, so we have done the extracanal. So we did the para-aortic lymphadenopathy, aorta, vasculitis, occlusion, vertebral bodies, disseminated malignancy, sarcoidosis, CRMO. I mean, rare things, but think about it. Yeah, sacrum, bilateral insufficiency fractures, spinous process. We looked at the Bastrup's disease, and the last case was desmoplastic fibroma. Going into the spinous process. So just a way of trying to categorize and make sure that you don't miss any of the lesions that are outside the canal, and the clinical history may actually make you focus only on the canal pathology, and you may miss these other things, but it's very important that you don't miss, because like I've shown you, you may be the first clinician to make the diagnosis for the patient. Okay, so thank you. And I just had one last thing. Please do consider strength training. I am going to compete in the World Championship in Manchester. So if anybody is around Manchester, I think it's the 12th of September. I will see you there. If you want to know the details, I think it's Pendulum Hotel or something like that. Okay, thank you. Thanks a lot.
Thank you very much. Absolutely brilliant, Priya, and another world championship. So best of luck for that. As the audience knows that Priya is a super athlete, black belt plus, I think, 10, 12 dans or something. And then ultra marathon runner, 100 mile she completed with her daughter. So we are very proud of you, Priya, and I hope that we are going to see the first radiologist world champion in Manchester. Best wishes.
Let's see. Thank you. Thanks a lot, Dr. Khan. It's very new, but like I said,
Uh,
challenges are good for everybody. So I think, and what I've learned is I have motivated some more people to take strength training. So that's the main purpose of the whole thing, of sharing this with everybody. So thank you. Thanks a lot.
Excellent, excellent. Thank you very much. Brilliant session. I learned a lot.
Thank you. And I'm very sorry about the hiccup with the IT in the beginning. I'm sorry about
No,
that.
no, don't worry. Absolutely, it happens. And with me, it happens every time. So don't worry.
Thank you. Thanks a lot.
Thank you
I'll
very
take
much.
leaves. Thank you.
Thank you. Now, let me actually, what is happening is that my video is not behaving. I'll cut out my video so that there is no confusion. Actually, I work through two laptops and there is a technical issue. Finally, we are there. Can you hear me, please?
Yes, sir, you're audible.
Okay, so let me, candidate one, are you a co-host?
Yes, sir, I am a co-host.
Okay, so this is your first case, three cases for you and three for candidate two. So this is a 69-year-old, and she is a known case of cholelithiasis. She presented with upper quadrant pain. An ultrasound was done, which they said that we could not see the gallbladder and ended up doing an MRCP. I'm showing you a MRCP series. I'm not interested in the EVAR. The patient had an EVAR, which you can see. I'm not interested there. So over to you.
So, I have been presented. Am I audible, sir?
Yes, you are.
I have been presented with an out-of-phase T1 weighted image, axial section in a
Excuse me, can I stop you? Is it a T1 weighted sequence?
uh,
Look at the
no,
CSF.
sorry. So it's a T2 weighted sequence,
Yeah,
heavily
yeah.
weighted T2. It's a axial T2 weighted sequence of a 60-year-old female patient who is presenting with right upper abdominal pain and is a known case of cholelithiasis. I'll just scroll from cranial
So
to caudally.
just please concentrate just on the gallbladder. Where is the gallbladder?
Yep. Uh, Scrolling inferiorly. I'll just take one more scroll. Okay, I can appreciate that the gallbladder appears to be collapsed, and it's seen within the GB fossa. It is appearing collapsed, and there are few heterogeneously hypointense signals within the GB lumen. These are consistent with that of cholelithiasis. I'm trying to look for any associated IHBRD. I am not able to appreciate any intrabiliary radicals which are dilated. The rest of the liver
Okay.
parenchyma appears.
So I've given you,
Okay.
here you are. Over to you.
Yeah. So this is the coronal T2 weighted sequence, Hayes sequence. Scrolling through the, there's a bit of lag. Yeah, now I can scroll. Scrolling through the sequences, uh, I appreciate that the portal vein appears to be normal, the liver appears to be normal. I'm trying to look for the collapsed gallbladder, which I could appreciate in the axial section. Uh, this tubular hypointense structure is likely the gallbladder, which is collapsed and has multiple calculi within.
Is it? Please reconsider that. Show me the gallbladder once again.
Um, so can you see my pointer?
Yes, I can, but that is not the gallbladder.
Okay. So I'm not able to visualize the gallbladder in these sequences. Then there is no IHBRD seen. The portal vein appears to be normal. Uh,
Right. This patient, after about 5 days, presented with in addition to the right upper quadrant pain, left lower quadrant pain, and then a CT scan was done. So let me show you the CT scan. Over to you.
So scrolling through the axial contrast enhanced CT sections of the abdomen. So, so I'm not able to scroll through the
Maybe you will
sequences.
have to ask again, I think,
Okay,
control
okay. Sure, sir, sure. Yes, I have requested again.
approved.
Yeah. So scrolling through the contrast enhanced CT sections of the abdomen, in the portovenous phase, I can see scrolling inferiorly that the patient is complaining of left lower quadrant pain. And I can see that there is evidence of a well-defined lamellated peripherally calcified lesion within the uh, proximal iliac loops. I'll just want to confirm the loop of bowel. Yeah, it is not the ilium, it is the descending colon. There is extensive surrounding fat stranding noted around this bowel loop with few air foci seen outside the bowel lumen, suggesting a concealed perforation. So this is a gallstone which has slipped into the descending colon uh, and is causing obstruction with surrounding extensive inflammatory changes and concealed perforation. I'll just want to have a quick look at the rest of the bowel loops to rule out any obstruction. The small bowel loops do not appear dilated. The large bowel loops are within the normal diameter range. So this is a case of a gallstone which has migrated into the descending colon, and this patient is having extensive inflammatory changes surrounding it. This is a red flag case. I red flag this case. I need to urgently convey my findings to the emergency team. This patient will be referred to the on-call surgical team for a surgical resection of the gallstone. And uh, the patient is also having changes of diverticulitis in the descending colon, for which it will be referred to the gastroenterology team afterwards. Thank you.
So, why is there inflammation surrounding this loop of descending colon?
Uh, because the gallstone has impacted itself within the descending colon, and there has been a focal perforation which has concealed itself.
Why is there focal perforation? Do you see any signs of obstruction at this point?
Uh, no, there is no proximal dilatation of the bowel loops, so there is
So why will it perforate then?
um, b- because of the pressure necrosis it will be causing, because it's a large stone, and there are surrounding changes of inflammation, and the wall of the descending colon appears to be
So
thickened.
from where did this calculus come into the colon?
Since I'll just want to have a scroll and look at the GB fossa once.
Mhm.
So yes, I still appreciate in the GB fossa there is a residual contracted gallbladder which has few radiodense calculi within. Also, there are multiple foci of air within, suggesting there has been a fistula between the duodenum and the gallbladder. So there has been a
Duodenum.
cholecystectomy.
Duodenum.
Yes, duodenum and the gallbladder, which has
Where is the
caused.
duodenum?
Just scrolling. So this is the collapsed gallbladder in the GB fossa, and I do appreciate that there is extensive surrounding fat stranding noted, and there seems to be a fistulous communication between this contracted gallbladder and the stomach.
Okay, thank you. So this is a case of cholecystocolo fistula. So the fistula is between gallbladder and the transverse colon, and rather the hepatic flexure. And so let me go back to the what we call the MR, and I'll take you through that. Now, on this MR, if we see carefully, what is happening is that this is the contracted gallbladder. It was correctly picked up by candidate. And but next to it, if we continue scrolling, in comes this loop of bowel. And this loop of bowel actually is the transverse colon. So the key point to remember is that anatomy-wise, the gallbladder is not far away from the proximal transverse colon or the hepatic flexure. And these fistula, I have seen quite a few cases in my experience, and one of them presented with obstruction. This one still is not obstructed. I'll come back to the CT in a while. So if you see here, anatomy-wise, this is that contracted gallbladder. You cannot make out that what is what, but you can make out that there is a loop of bowel here. And this loop of bowel is the colon. The CT, of course, will show it in a much better way. So on the CT, we can see that these are the intrahepatic ducts. This is the CPD. Now, as we come here, this is that contracted gallbladder coming into our view. And we can see some stones, etc. There is a locule of gas here, and then it goes into this, the large bowel. So actually, this large bowel, this is the hepatic flexure, and then you can see that the transfer colon goes across the spine to the other side, and ultimately we have got the splenic flexure, and then the stone comes here. So basically, what is happening at this point, the pathophysiology of the inflammation is diverticulitis at this point. It is not because of obstruction. So what has happened is that you can see many diverticuli. So the stone has, of course, impacted here. And with that, you can imagine that the pressure within the intraluminal pressure has increased, and that some of the diverticuli, they have burst. When they burst, then there is evidence of secondary diverticulitis. Uh, Once I've seen, I think I've shown you this case in my teachings where a patient presented with complete obstruction, large bowel obstruction with the same pathology. And please remember that when there is diverticulitis, there can be diverticular stricture because the muscularis, there is hypertrophy of muscularis. In that particular case, the patient presented with large bowel obstruction. So as far as confusion with duodenum is concerned, for duodenum, always, the pancreas is your friend because this is the SMV, this is a reference point, and we can see that this is the head of the pancreas, this is the neck. The process of pancreas which is below the SMV. This is the uncinate process. So just remember it like this, that duodenum D2 will be next to it. They cannot change position. So this is all D2, and then it will become D3, and it will then go to the other side, cross over to the other side. So the main point here is that the fistula was between the gallbladder and the colon. Okay, next
Yes.
case. So this case is a 42-year-old female, off and on headache, dizziness. These are her complaints. Over to you.
So I'm requesting for the remote control, sir.
So somebody has asked a question in chat regarding the diverticuli. No, the patient had inherently there were diverticuli, and because of the impacted stone, the intraluminal pressure has increased, and that is why now it is diverticulitis. Please remember the pathophysiology of diverticulitis. Diverticulitis cannot happen without macroscopic or microscopic perforation of a diverticuli. It only happens when the wall is gone, because in a diverticuli there is only mucosa, there is no muscularis, etc. And of course, there can be serosa also. So, uh, and that is why at times you will see air bubbles next to the colon or in the sigmoid mesentery. And of course, in a frank case, you might see pneumoperitoneum. So that is the pathophysiology. So diverticuli did not happen because of the impacted stone, but there were inherent diverticuli which, they converted to diverticulitis because of the phenomena which I have explained. Okay, over to you. 42-year-old female, and this female has got headache off and on and dizziness.
Okay, so I've been presented with axial MRI flare sequence of a 42-year-old female patient presenting with off and on dizziness and headache. I'll just want to scroll through the entire stack of sequence once from caudally to cranially. So scrolling cranially, I am looking at the brain parenchyma. There is, till now, I do not appreciate any altered signal intensity within the brain parenchyma. The sulcal spaces appears to be normal. There is no evidence of hydrocephalus. Uh, However, I appreciate in the given sections that there is evidence of few subependymal nodules in the bilateral frontal region appearing isointense to the white matter in the subependymal region. Um, Scrolling inferiorly, the rest of the ventricles appears normal. The basal ganglia and the thalamus appears to be normal. There is no hydrocephalus. There is no crowding at the foramen magnum noted. So in my routine clinical practice, I'll be seeing a T2 weighted sequence if available.
I'll show you a T2. Just hold on, please. Don't scroll.
Sure.
T2 with you.
So scrolling through the T2 weighted sequence again. I'll focus on the bifrontal lateral ventricles, but I'm not able to appreciate those subependymal nodules in this section. Scrolling inferiorly, the rest of the brain parenchyma appears to be normal. Do we have a post-contrast enhanced sequence which I can see?
So whatever you want to see is visible on this sequence.
Since the patient is presenting with off and on dizziness and headaches, I am focusing on the ventricles. However, the ventricles are not dilated. There is no altered signal intensity seen in the brain parenchyma. Um, I'll be looking at the flow voids of the dural venous sinuses, and they appear to be normal.
Look at the foramen magnum.
So, looking at the foramen magnum, there is uh, there's change in shape of the normal the foramen magnum coming inferiorly. Sorry, it's jumping a bit. Yes, I see that there is evidence of crowding at the foramen of magnum with inferior tonsillar herniation noted. Uh, in my routine clinical practice, will be seeing a sagittal T2-weighted sequence to measure the tonsillar ectopia. Um, yes, on the sagittal T1 weighted sequence, I can see that there is inferior basilar herniation of the cerebellar tonsils, and there is crowding at the foramen magnum with associated intramedullary widening of the cervical spine with hypointensity within the cord from C2 to C4 region vertebra, suggesting a syrinx. So these findings together are suggestive of type 1 Arnold-Chiari uh, syndrome. I'll be conveying my findings to the referring clinician. Would also want to screen the entire neural axis to look for any open spinal bifida if associated with it. And I'll be referring this patient urgently to the neurosurgery team for further management.
What is the criteria to measure the tonsillar descent? How much? I'm talking about
Uh,
measurements.
yes,
What is
sir.
that?
So a line is drawn from between the basin of ischion line and any tonsillar herniation more than 5 millimeters is considered to be abnormal.
Do you think that the symptoms of this patient is because of this carry one malformation?
Uh, so I do not see any obvious gross hydrocephalus in this patient. But however, there is a syrinx formation in the cervical cord, which could be the reason of off and on headache and dizziness.
So what is the treatment?
So treatment in this case, because the patient is symptomatic, they will need to do a decompression of the foramen magnum in this case to relieve the patient of symptoms of the overcrowding.
Okay, thank you. Now, interestingly, of course, this type of case has been shown to you many, many times, and it was simple as that. Very interesting that I don't know if you realize that you actually, when you were scrolling through the flare, you actually said that there is no, overcrowding of foramen of magna.
Yes,
Do you remember that, or you
yes,
don't?
I did. I think I jumped
Yeah.
that
So,
particular sequence.
so this is very interesting. But having said that, if you learn from this, basically, how do we train our minds is that we have got a protocol, and at times our eyes are not looking at the things, and we convince ourselves that we have. So this was too interesting, right?
Yes, sir.
So yeah. So the point is that there will be a bit of lag between the eye seeing it and instead of narrating the protocol. So that will be the learning point from my side. So your protocol was brilliant, and the finding was very obvious, right? Okay, now if you see here on this flare sequence, we can see that this is the cord, and we can see the tonsil which is wrapped around it. And in the exam, it's quite a common case, and they will always show you axial, and they expect you to pick it up on axial. On this T2 weighted sequence, you can see this is the cord, and this is the tonsil. Now, a few concepts about this. You were absolutely fine regarding to measure it. This is the basion. Basion is the anterior margin of the foramen magnum, and this is the opistheon, which is the posterior. So if you draw a line from here till here, and then try to measure how much is the tonsil inferior to that. So this is about 1.6 centimeter or 16 millimeter. Now, and with that, the shape of the tonsil might be not rounded, but peck shape, and the folia might be, oriented vertically. And with that, there is a syrinx there. Now, please remember that Carry-1 malformation in most of the cases is an incidental finding of no clinical significance. Having said that, it can cause lot of symptoms, and the correlation is made on the basis of the descent. More than 12 millimeter, all patients will be symptomatic. So my question indirectly was the fine touch of this. Do you know this knowledge? This is what I was asking. More than 12 millimeter, because if you would have said that I will measure, I would have given you the measurement. So because the clinician at times they will ask you, of course, the neurosurgeons will make their own decision. What do you think? And uh, more than 12 studies have told us that it is always symptomatic. So otherwise, your concept of decompression posteriorly, that was fine. And your concept that the whole neural axis is fine. In this particular case, we had a spine, we did a spine. There was a syrinx here, but there was no syrinx in the what we call anywhere else. So let me show you. So this was the syrinx in the cord, cervical, but nothing anywhere else. Okay.
Yes, sir.
Next, please. So next is my software. I don't know what is happening. Usually it goes from one case to the second. This today, what is happening? It just collapses. So I have to again open it, which is very irritating. In any case, over to you. You love head and neck, isn't it?
Sir, yes, sir.
He's laughing. He's laughing, huh?
Oh, sir.
Yes. No, sir. So this case I have put for anatomy, and all my questions are going to be on anatomy. I warn you. Having said that, 74-year-old male, hoarseness of voice. Over to you.
Yes, sir. So I've been presented axial contrast
So again,
enhanced.
you will have to ask for the mouse, I believe.
Oh, yes, sir.
Yes.
These are contrast enhanced CT sections of the neck of a 74-year-old male who is presenting with hoarseness. I'm scrolling through this given sequences. Yeah. Scrolling cranially. Okay, now I'll just have a moment and scroll caudally. Scrolling caudally, the paranasal sinus appears normal. I'm focusing in the region of the oropharynx. The oropharynx appears normal. The vallicula appears to be normal. Uh, Scrolling inferiorly, I appreciate um, that there is evidence of the vocal cord, the left true vocal cord. Okay, scrolling. Yeah, there is evidence of a heterogeneously altered enhancing mass lesion seen in the region of the left glottis.
Where
Uh,
is the left glottis? Where is the glottis?
so this is the in the supraglottic region. Sorry, I'll retract my statement.
Okay.
There's some lag in the scrolling, so sorry. Um, this is yeah. So in the left supraglottic region, there is evidence of a heterogeneously enhancing soft tissue mass lesion noted, which is involving the left aryepiglottic uh, fold and is also causing effacement of the left uh, piriform sinus. There is a luminal narrowing of the supraglottic region, and this lesion is noted at and above the level of the hyoid bone. Scrolling inferiorly, the false vocal cord and the true vocal cord appears separate from the lesion. Now in my routine practice, I'll be looking at the cervical group of lymph nodes since I'm suspecting this to be a neoplastic lesion. Scrolling inferiorly, I see that there is evidence of heterogeneously hypoechoic,
Hypodense, huh?
hypodense, sorry, lymph nodal mass seen in the region of superior, in the posterior to the trachea, and which is seen anterior to the which is anterior to the esophagus, and it is displacing and abutting the esophagus posteriorly. Okay. Scrolling inferiorly, I appreciate that there is an heterogeneously enhancing circumferential lesion involving the esophagus, anterior wall of esophagus actually, which is extending anteriorly into the tracheoesophageal groove. So since the patient is presenting with hoarseness of voice, my top differential in this case will be that of a mass lesion involving the supraglottis. Uh, with the mediastinal lymphadenopathy, with necrotic mediastinal lymphadenopathy, um, which is also seen infiltrating the anterior wall of esophagus. In my routine clinical practice, I'll be conveying my findings to the referring
You can
clinician. This
just give
patient.
me your one-line conclusion. What is your final conclusion?
So can I review the scan in the sagittal plane for
No.
um, so my conclusion would include that there is a neoplastic mass lesion which is sitting in the tracheoesophageal groove, and is causing infiltration of the anterior wall of the esophagus. And it's also infiltrating and displacing the trachea anteriorly. Um, and this will need referral to the ENT surgery team for a endoscopic evaluation and a biopsy, followed by a contrast-enhanced CECT chest abdomen pelvis for staging of the disease.
So where is the primary? Which organ, from which organ is the primary tumor?
So the primary lies is likely arising from the esophagus, the thoracic
Okay, thank
esophagus,
you.
and it's
Thank you. So the point is that this case uh, is a case of post-cricoid esophageal carcinoma. And with that, if you see, you are in the territory of, that recurrent laryngeal nerve, though the findings regarding the larynx are equivocal. But having said that, I had just told you that the patient presented with hoarseness, and that was because of the recurrent laryngeal nerve. So what is happening is the fine touch. What is happening? This is the valliculi. This is the glossoepiglottic fold. This is the ariepiglottic fold. We are going inferiorly. Now here, this is the piriform sinus on the other side. And as we go here, the key thing is that where you will see two, uh, two cartilages, one anterior and one posterior. This is the level of the true cord. So this is the level of the true cord, and so this is where the true cord is. Actually, you don't see much here. There usually when there is a bit of asymmetry, but not very gross. If I go superior, there is, this enhancement which you were calling, that is, quite a equivocal type of a finding. Usually, you won't even see enhancement as far as larynx is concerned. Now, the presentation is why you got confused, because hoarseness, and this is what happened in the real life. That is why neck was scanned, and with laryngeal protocol, without held respiration. Having said that, the main pathology is a post-cricoid uh, carcinoma of the esophagus. So from here downwards, now we are at the cricoid cartilage level. If you can see here that the esophagus usually is sitting here. Instead of that, there is a mass sitting there. And as we go down, this mass is invading. We can see that it is invading the cricoid cartilage. Next cut, it is invading the trachea. It is definitely going into the trachea. One pitfall here is that the posterior wall of the trachea, where I'm pointing out, usually there is no cartilage there. But sometimes there is indentation by the esophageal carcinoma, and you might overcall it. And that is why, if that is a point of discussion, then we advise a E-bus, endobronchial ultrasound. So in UK, we have got E-bus facility where the respiratory people, they do it, they go into the trachea and see if there is a mass sitting in the trachea. In this particular case, it is fulminant, it is, obvious. With that, now this mass is also invading the thyroid gland. It is infiltrating the thyroid gland. And you can hear this, the epicenter is up here. And then even now it continues around the esophagus and continues here. And you can see this lymphadenopathy right and left. And some of these are necrotic. Look at this one. This is necrotic lymph node. So the recurrent laryngeal nerve is involved. You remember that whenever a patient like this comes to you, we usually ask for a chest scan. In this particular case, luckily, they had included in the field of view a bit of chest also, but not more than this. But you can actually see everything happening. So post-cricoid esophageal carcinoma with extension into the cricoid cartilage, into the thyroid gland, into the trachea. This is a T4 tumor, non-operable tumor, and with that there is lymphadenopathy, any hoarseness, etc. We don't have any gross findings in the larynx, but whatever is happening because of the recurrent laryngeal nerve. Okay, thank you, candidate one.
Thank you, sir.
So you do love neck, isn't it? Candidate one.
Uh, so,
Yes.
yeah, sir, like it, but I made a mistake. I should have scrolled to the very end in the case.
Yeah,
So,
yeah. So yeah, you
I,
see that thing triggered. So you have to learn from each and every experience. You knew this case also. You knew
yes,
the stuff, but because of that hoarseness, and please remember this is what happened in the real world also.
yes,
Because of that hoarseness thing, you got you just sort of wasted all of your time on the larynx, isn't it?
yes, sir. Yes,
Okay,
I'll
then, well
keep it
done.
in mind. Thank you, sir.
Yeah, well done. Okay, now, candidate two, are you with us?
Yes, doctor, I'm here.
Okay, so candidate two, this is a case from A&E. Patient is alcoholic, 57-year-old male, presented to A&E, has got headache for about 10 days. Patient is quite disoriented. They don't know it is because of alcoholism or something else. In any case, they did a CT. So this is the CT. Over to you.
Okay, so I'm present with anxiety, the brain trying to scroll. It's not scrolling. Oh, so
Let me change the densities for you again. Just 1 second. Don't move your mouse.
okay,
Now you can move.
okay. It's not scrolling. I don't know why.
So if it is, that red bar on the top,
Yeah, I
hold
can
it
see.
and scroll left and right. That is another method to scroll it if the mouse is not working for you.
Okay, doctor, yes, it's working now. So anxiety, non-contrast of the brain of a alcoholic patient who was presented to the A&E. I'll just scroll through the whole stack of images before giving my comment. Okay, I'll just scroll to the last cut on the caudal side as well. Okay, so this is the last cut. Okay, so on scrolling, I could see hypodense lesion seen within the left posterior parietal region on the left side, with loss of the gray-white matter differentiation. I'm suspecting some hyperdensity within as well, but in my routine practice, I would change the window a little just to see this better if this consistent with hemorrhage or not. Also, I could see some hyperdensity within the posterior part of the falx. This could be just artifact, or it could be representing hemorrhage within the posterior part and keeping with subdural hemorrhage. Um, Also, I could see hyperdensity as well within the Sylvian fissure on the right side. Again, this could be a dense loaf sign of one of the right MCA branches. But as I will adjust the window in function window just to see this better.
Are where are you worried about this MCA sign?
Can you see my cursor?
Yeah.
Yeah, at this point, I thought it's hyperdense, but I would just adjust the window just
There
to
was no
confirm.
infarction of the MCA. Don't worry
Okay.
about an MCA infarction.
Okay, so the left posterior parietal region hypodensity with area of hyperdensity, then I'm worried about this. And if the high density in the posterior part of the fox is not artifact, so I'm worried about maybe hemorrhagic venous infarction with venous sinus thrombosis.
Why are you worried?
Because of the
Can
presentation
you
of
scroll? Can you show me what what have yeah? Why do you say a venous infarction?
It's not projecting well actually on this window, but I think I'm suspecting some hypodensity within this part, within the left parietal region, with also suspecting some high density within. This could represent hemorrhage and extend to the cortex. So I'm
So, madam,
suspecting.
can you scroll, please? Why are you just on one static image? Yeah, you're doing well. Actually, you are pointing out to correct things, but please show me why are you saying that this is a venous infarction?
Okay, so I'll take a look one more time upon the sinuses. Okay, this is the last cut. Scroll one more time cranially. Okay, so the appearance on the left parietal region could be bilateral, but more prominent on the left side. So two differences in the case could be hemorrhagic venous infarction with dural sinus thrombosis. Other differential could be PRIS, which is posterior reversible encephalopathy syndrome.
So,
So I would,
why are you? My question is that why do you think that this is a venous infarction?
because of the appearance, um, it doesn't have a territorial distribution to be calling it ischemic. Also, the hemorrhage within the hypotensity, would maybe,
Any other evidence on this CT?
yeah, the high density within the posterior part of the fox, and also maybe here in this
Where is it?
cut. And here, I think it's within internal cerebral veins and the straight sinus.
Okay. And
This is urgent finding. Would immediately pick up the phone and call the neurological team for arrangement of CT venography to better assess the sinuses. And upon the results of the scan, I would request starting of the anticoagulants. Okay, so this is
an MR was done.
okay. Should I request control one more time?
Possibly, yes.
Okay. So axial MRI flare sequences of the same patient. Okay. Just scroll through the whole stack of images. Just complete the scrolling to the last cut, then come back to the region of interest. Okay, so upon scrolling, I could see the region, the hypodensity seen on the CT appears to be well-defined hyperintense abnormal signal intensity within the left posterior parietal region, with peripheral area of low signal intensity in keeping with hemosiderin rim, and there is also surrounding area of high signal intensity in keeping with edema, causing some effacement of adjacent cortical sulci, but no definite effacement of the ventricles or midline shift, no definite hydrocephalus as well. Um, so it appears to be well-defined lesion. So I would like to correlate with other sequences like T2 and SWI and post-contrast as well.
This is the T2.
Okay.
Because of time factor, I am showing you.
Okay. So
And now this is the SWI.
okay. So the lesion shows pluming on SWI in keeping with blood products with the low signal intensity hemosiderin as well. This is hemorrhagic lesion. Uh, but I couldn't appreciate any effacement of subarachnoid spaces on the CT scan we've seen. Okay.
This is the DWI.
It shows the restriction centrally, so I would correlate with ADC and
This is
also
the ADC.
yeah, so this is true diffusion restriction. Um,
What do you
so
think is happening?
can I see a post contrast as well?
So this is a pre-contrast T1.
Okay. So it shows high signal intensity periphery in keeping with hemorrhage.
And this is the post-contrast.
Doesn't seem to show much contrast enhancement. So for the central diffusion restriction for intraparenchymal lesion,
There is enhancement. All of this is enhancing, though it was high signal, but it is enhancing.
okay, so this could represent with this. I was first thinking about cavernoma as it showing pluming on the SWI sequence, and also I can see normal enhancement of the dura vena sciences, so that it excludes the possibility of venous infarction now. Maybe there's maybe filling defect within the posterior part of the spine.
Okay, so just give me your final conclusion.
So this appears to be a well-defined lesion with central diffusion restriction and peripheral enhancement. This could represent an abscess, but the blooming on the SWI, also I would put cavernoma in the differential, but cavernoma usually doesn't show any mass effect or enhancement or central diffusion restriction as well. So I would correlate with patient history of having fever or raised inflammatory markers.
Okay, thank you. You see, my main point for you is that you have picked up a finding, but you are not at all correlating, though the point is that you had picked up some high density, and but you changed your direction quite a few times, and which is what I was, as an examiner, I was asking you to show me that why it is what it is, and you had pointed it out, but then you just went back to the lesion again and again. And this is what you did in the MR also. In any case, this is a interesting case presented with venous sinus thrombosis, with venous infarction, sorry, dural venous sinus thrombosis with infarction. The patient apparently, because the alcoholic patient means the history becomes very dicey, but the patient had symptoms for more than 10 days or so. Now, on this scan, if you see here, there is a bit of hemorrhage, and with that, there is a bit of edema, quite a significant amount of vasogenic edema, more than usually seen in venous infarctions. But even here, if you call it a venous infarct, absolutely fine, because you pointed out that it is not in a vascular territory and it is hemorrhagic, it is peripheral, absolutely fine. Now, with that, what is happening? What is happening is that you have had to be very emphatic in this. You pointed it out, but not to a level where again and again. So you wasted a lot of time in that. Now, in any case, this is the straight sinus. These are not the internal cerebral veins. Internal cerebral veins will be in this area where I am pointing out. This is the straight sinus. It is high density, and it is high density. The transverse sinus is high density. Now, as we go superiorly, this is the superior sagittal sinus. Still, it is high density. And if we go all the way here, this is all high density. So everything is thrombosed in a way. And though I had not shown you uh, coronal, but just to show you for teaching purposes, that this is the superior sagittal sinus, and we can see it is all high density, and it dips down here, and on the right side it is prominent. Maybe on the left side it is a hypoplastic or a smaller sinus, and everything looks thrombosed. You did well where you asked for a venogram, which was the correct way to deal with it, because in the real world, we don't have luxury to ask for MR urgently. Venograms can be done urgently. Sometimes what happens is that if you can do so my point is that you can be given a CT venogram, and you can also be given an MR after this by the examiner. Now, in this particular case here, this was, if you see here, there is surrounding hemosiderin type. This is we'll go back to the T2 to make that judgment. This is that hematoma. There is vasogenic edema. Even here, if we go superiorly, we can convince ourselves that on this flare sequence, that something is sitting in the dural venous sinus. Even here, we can convince ourselves that something is happening in the transverse sinus. Then we go to the T2 weighted sequence. On the T2 weighted sequence, we can see that there is a hemorrhagic focus. Low signal rim means hemosiderin. So, and central is high signal. And then if we go superiorly here, we can see that there is a bit of signal in the superior sagittal sinus. Even here, there is a bit of signal, means thrombus. Now, let's go back to the SWI. So on SWI, there is hemorrhage, and in the central region, there looks like less of a hemorrhage. Interesting finding was on the DWI sequence. On the DWI sequence, there is central restricted diffusion. Central restricted diffusion. And on ADC map, it is hypo. Now, if we go to T1 weighted sequence, it shows high signal. This is pre-contrast T1. So there is some hemorrhage in the wall of this lesion. And on post-contrast, it enhances. So this is interesting case where there is a dural venous sinus thrombosis and with an abscess formation. Secondary abscess formation, neglected case because of the alcoholic, history. The enhancement pattern here is a bit of, slightly irregular, and we should be worried if there is anything, and we have to ask for a delayed scan. Having said that, if you see the dural venous sinus, all of it has got a filling defect. This is a filling defect, and filling defect, this is that empty delta sign, and filling, you can see this filling defect there. You can see this filling defect all the way going here. Actually, on the left side also, the sinus is smaller as compared to the right, but you can see this filling defect. So it is, and you can see that this sigmoid sinus is communicating with this abscess here. I did not show you a coronal, but just to teach you, let me show you a coronal. And here we can see this is that lesion, and that lesion communicates here with the, and there is a filling defect there with, uh, gross dural venous sinus thrombosis. And you can also look at the superior sagittal sinus, this one where it has got a filling defect. All said and done, this case was an interesting case, a neglected case. That's why I think there was secondary infection which developed. Uh, Dural venous sinus thrombosis, high density, it comes in the exam. Many a times it has come, and look for that. Number one, in this particular case, I think an extended finding was the secondary abscess formation. Okay, next case. Okay, this is the second last case of the day. So let me give you the history. This is 80-year-old, and on ultrasound, they said that there appears to be some cholelithiasis, and is there any mass adjacent? They were a bit confused. So an MRCP was done. They said that there is possible cholelithiasis and question mark mass adjacent to the gallbladder. And that is why an MRCP was done. And I'm showing you an MRCP. Over to you. I'm just showing you the T2 series of the MRCP.
Okay, so this is T2 outer phase of the MRCB and a patient presented with cholestasis and asking for if there is a mass or not. Just scroll through the whole stack of images for giving my comment.
Just concentrate on the gallbladder and perigallbladder, nothing else.
Okay. So upon scrolling, I could see multiple dilated intrahepatic biliary radicals within the liver, but no evidence of stones or calculi within the biliary ducts. The gallbladder appears to be well distended. I'm tracing the gallbladder for any evidence of calculi or mass lesions.
Around the gallbladder, do you see anything?
I think I'm suspecting a circumferential mural thickening in the second part of the duodenum adjacent to the gallbladder.
Right.
So I'll just, in my routine practice, I will look at that in multiple plans just to confirm it, and a post contrast would be.
Just 1 second, please. I'll give you a coronal. Over to you. Just 1 second. Over to you.
Okay. So this is coronal imaging of the same patient. I'll go to the region of interest, which is the duodenum of second part of the duodenum. Yeah, I think this is the mass lesion I've seen on the axial view. I'm looking for any proximal dilatation of the stomach and proximal duodenum as well. You can actually appreciate gross dilatation. So I'm suspecting duodenal carcinoma, but also duodenitis couldn't be excluded. So I think a CT would be better to assess the smoldering of adjacent fat planes of the duodenum, and a post.
I'll show you a CT. Just 1 second. Here you are.
Okay, I'll just press control one more time.
improved.
Thank you. So this is axial CT post contrast of the same patient. Trying to scroll. Yeah. Okay, so focusing on the region of the duodenum. Okay, there appears to be circumferential mural thickening within the second part of the duodenum with some proximal dilatation of the first part. But no definite extension beyond the wall of the duodenum. There is some adjacent lymphadenopathy as well. So in my routine practice, I would complete the study to look for any evidence of metastasis. And looking at the lung.
Don't worry about the metastasis. Come back to the lesion. What are the characteristics of the lesion?
It's hyper. I think it's hyper enhancing, but a pre-contrast would be helpful to compare the.
On pre-contrast, there was no high density in the lesion.
Yes, so there is some enhancement within the lesion and some cystic changes as well. There used to be exophatic actually beyond the wall of the duodenum. So I put just in the differential gastrointestinal stromal tumor.
Gastrointestinal stromal tumors will enhance like this?
It's usually large exophatic masses with heterogeneous appearance and calcifications.
My question is, will it enhance like this?
I think it has a malignant potential, so it could enhance.
Madam, answer my question. Will they enhance like this?
I think yes, if they have turned malignant, they could enhance.
Never like this. Please continue. Now, why is it enhancing? What do you think it is?
Could be either a primary malignancy within the duodenum, or could be metastasis from another malignancy that's not known to the patient. Other differential could be.
Let me give you a hint.
Yeah.
Enhancing lesion in the pancreas.
Neuroendocrine tumor is a possibility as well. I was looking at the stomach for any gastric roget thickening to exclude gastrinoma possibility in the gastrinoma triad.
Okay, the lesion, so is it malignant or is it benign? What do you think?
I think it's confined to the duodenum. It doesn't invade adjacent structures. So I would recommend doing a nuclear scan study to exclude the possibility of a neuroendocrine tumor of the pancreas. And according to the results of that, we can do a biopsy if it's negative.
Yeah, so the patient initially refused an OGD. So the patient is 80 years old and they did we wanted to do a barium just to, on barium criteria, what do you think, this lesion looks malignant or benign? Oh, I think you are not seeing the screen, right?
Yeah.
Just 1 second. Yes.
Okay, so this is contrast follow through of the same patient. I'm looking at regions of interest.
Contrast?
Follow through, meal and follow through.
What is a follow through?
If it's shown the bowel loops, the small bowel should be a follow through.
What is a meal?
Sorry?
What is a barium meal? What is a barium follow through?
Barium meal is only to the stomach. I think if it's delayed, it would be barium follow through.
So what is this examination?
I think the stomach is shown, so this could be a barium meal.
Continue, please.
There is a short segment narrowing in the second part of the duodenum, with abrupt caliber change and apple core appearance. So I would be yeah. So it's surrounding the lumen from both sides rather than arising from just one side. I would be worried about this case. I would not exclude malignancy from my differential. So again, nuclear scan would be helpful to exclude neuroendocrine tumors, and if negative, I would proceed with biopsy.
Yeah, that's fine. Okay, this case, what happened was that this was an incidentally, I'll just show you the from the beginning. This is a very interesting presentation because what happened was that presentation is, as I pointed out, can you imagine it was picked up on this MRCP incidental? So this is a neuroendocrine tumor of the duodenum. Initially, the patient did not even accept OGD. So then barium was done, and then it was confirmed. We were quite emphatic that this is malignancy, and ultimately the patient had a surgery also. So the histology was neuroendocrine tumor. So what are the learning points in this case? Now, the learning points are that you can see these filling defects. So these were small calculi which are sitting there. Now, with that, you can see that the second part of duodenum shows circumferential type of mural thickening. So though the mural thickening is quite significant on the medial side, but it goes here also. And look at our landmarks here. So this is the head of pancreas, and we can see these pancreatic duct and the CVD there. So this is the second part of duodenum. So proximal to that, one of the relevant things is there obstruction? And there is not any obstruction. And that is why it was quite a stenotic type of lesion, but still not causing complete obstruction. The same lesion is here in the duodenum. And again, you can see that there is no obstruction. Candidate asked for a CT, which was the correct answer. So well done for that. And then on CT, the enhancement pattern is quite unique. And this was a sort of an exam point in this case. Carcinomas and things like that, they will never enhance. This is enhancing like anything, as if there is puddling of contrast. Please also, very rarely, there can be hemangiomas in the gut. I have seen quite a few of them. But they will have, so that's a vascular malformation. They will not cause this kind of mural thickening, and there might be flavolets. So this enhancement is something which should have triggered a thought process. Why is this enhancement there? And please remember that pancreatic neuroendocrine tumor, we know that they can be in the pancreas and they can be extrapancreatic. And of course, in GIT world, there can be neuroendocrine tumors in the whole of the gut actually. But this enhancement was a key thing here. Again, there is no proximal obstruction. And though nobody in the real world should have done a barium for this case, but we did it for the reason that the patient was refusing an OGD initially because of age factor. So this is a barium meal, and you have to know this terminology. Barium solo is esophagus. Barium meal is stomach and duodenum. Barium meal follow through is whole of the small bowel till the ileocecal junction, and barium enema, of course, is the large bowel. So this was well described that this is an apple-cole region lesion with overhanging edges and mucosal destruction. So the pattern is in keeping with what we call malignant lesion. So neuroendocrine tumors can be benign and neuroendocrine tumors can be malignant. It must be a slow-growing lesion sitting there since ages, still hasn't caused any obstruction. So last case of the day. Last case of the day. Madam, this is, ask for the mouse, please.
Okay.
Now, this case is a 38-year-old female presented with right neck swelling. right neck swelling. Ultrasound did not pick up anything, but they asked for the MR. Over to you.
Okay, so I'm presented with axial stair images of the neck of a female patient presenting with right neck swelling. I'll just scroll through the whole stack of images before giving my comment. Okay, so scrolling the other way to the last cut. Okay, so upon
So
scrolling, I
in
can
the exam, never keep quiet. You are quiet for too long, and you keep describing what you are looking at. Never be quiet in the exam.
yes, I could see a marker upon the right side. This could be the side of the swelling.
Yeah, very good. Well done.
Yeah, I'm closely examining this area.
Mm.
Okay, I could see some abnormal intensity within the right sublingual region extending into submandibular region on the right side as well. Yes, it appears to be hyper intense signal intensity on the stare. This could represent the submandibular gland that's dilated, or it could be diving granula. Um,
Can you point out where is the diving? Yeah, what is?
I was thinking about the submandibular duct first. This could be the course of the submandibular duct that's dilated.
Okay.
Um, but I cannot appreciate any filling defects within the duct itself to indicate stones. However, I would like to correlate with other sequences like T2.
This stir is a T2.
I think there is some filling defect here.
Yeah,
This could represent the stone within the submandibular duct, causing
right.
submandibular duct dilatation and possibly sialadenitis within the right submandibular gland. Um, So I would like to review other sequences to better assess the submandibular gland itself. Like if there's a post contrast.
Yeah,
Uh,
I'll give you a post contrast. Here you are, post contrast.
thank you. Okay, so the examining the right submandibular gland appears to be enhancing in comparison to the left side. Um, and the duct itself appears to be marginally enhancing as well. So I'm suspecting some element of infection, sialadenitis due to the stone. Um, Also, I would like to exclude any abscess formation, so I would be looking at the diffusion sequence if available.
Are there any signs of abscess on this sequence?
I don't see a well-defined collection, but I see just evidence of inflammation, enlargement, enhancement of both the duct and the gland on the right side. So
So
this is
just conclusion.
So this is urgent finding, right, acute sialadenitis of the submandibular gland. So I would call the head and neck team for removal of the stone and starting of antibiotic therapy.
Okay, good, well done.
Thank you.
Now, if you see here, in this case, what is happening is that when we do an MR of the neck, we do a stir sequence. This is a stir sequence. We also do a T1 non-contrast. And then we do a T1 fat saturated pre-contrast, and we do a T1 fat saturated post-contrast. So on this stir sequence, the candidate picked up very well that there is a capsule here, and this is what the radiographers do. They mark. Please remember I told you that there was nothing picked up on ultrasound. So on ultrasound, if there is a stone in the submandibular gland, etc., of course, that is part of our mandate, should I say. Now, if you see here, this is the submandibular gland and the submandibular duct, which is now this is the omohyoid. So this is the lingual duct where lingual gland or lingual space also. And we can see that it is going all the way here. And the key finding was that actually there is a stone. There is a stone which is actually projecting at the opening. So this is causing that ductal dilatation. So the candidate did well, asked for a post contrast. Now, on the post contrast, we can see that on this side, some enhancement, it is more enhancing as compared to the left. And so DWI sequence, you know, that is not asked for, or there is no need to ask for it in neck also. We don't do that in a routine. The point is that if there is an abscess, it will be rim enhancing with cystic. So there was no abscess there. Be confident. Now, my point is that don't go home with this idea that like brain, we will ask for a DWI in neck. Now, so in conclusion, this is a case of ductal stone of the submandibular duct with sialectasis. Sialectasis means dilatation of the duct, and with sialadenitis. So these words should be in your vocabulary. Now, sialectasis means the main duct can be dilated and the branch ducts can be dilated. In this particular case, the branch ducts are not significantly except here where I'm pointing out. If I show you T2 coronal, that is also a good sequence for this. Some lymph nodes here, which are on both sides, there are lymph nodes. So you can see that this is the duct here. This is the duct here. It is not clearly, you know, the intraparenchymal duct. But now the main pancreatic, submandibular duct, you can see how it goes. So it is going into the lingual space. And at the last bit, there is a calculus. And if you see it clinically, maybe it will be projecting at the opening. So sialectasis with stone and secondary sinusitis. Well done.
Thank you.
Right. So thank you. Any questions or anything?
Can I ask a question, please?
Sure.
Should we recommend like oral ultrasound to see the stone if it's in the submandibular location?
Oral ultrasound? No,
Yes.
no need.
Okay.
You know, it is there, the stones in the anterior 1/3 of submandibular duct. The ENT, they can remove it, but if it is more distal, means towards the submandibular, they have to remove the gland also. You have made the diagnosis, there is nothing there to confirm it. No need of confirming.
Thank you.
No further need to confirm it. And another thing is that on a CT, the stone will of course. So in real practice, what happens is that in this salivary glands, if you are worried, you can ask for a CT scan to confirm the stone if you want it, because it will be calcified. Please remember, in neck, there is never any need of asking for a non-enhanced scan in this perspective. So it is not like an IVU or something, because there will never be any vessels or enhancement to confuse yourself with a stone. You just do with with contrast. So if you want to do a CT. Have I answered your question?
Yes, yes, doctor. Thank you so much.
Okay. Anything else? What will be the management? ENT referral? Yeah, that will be the management, and they will remove the stone. It will be easy for them to remove. Anything else? Was there abdominal aortic aneurysm? So you see, I had told you that the patient had an EVAR, and I'm not interested. So yes, we knew that there is an EVAR. This was not a gallstone ileus. Ileus means gallstone ileus is small bowel. This was a stone in the large bowel. So the fistula was between the gallbladder and the colon. It is different than usually what happens is that the fistula is between the gallbladder and the duodenum, and from the duodenum it goes into the small bowel. And usually in the ileum, what happens is that the caliber decreases. We know that jejunum is bigger caliber and ileum is less. So the stone usually the classical site is ileum. So don't confuse it with gallstone ileus. Ileus, by the way, is a sort of a misnomer, but this is how we call it. In this case, the fistula was between the gallbladder and the colon and hepatic flexure. And from there, it went into this. So gysts, they do not enhance like this. It was very, very profuse enhancement. Somebody is asking that why it was a neuroendocrine tumor. So, this enhancement was as if there is vascular enhancement. Gysts do not enhance. There is a size criteria for gyst more than 5 centimeter. We call it malignant. We can be malignant, but enhancement pattern is what we were talking about. So, should we ask for CT for better visualization of stone? Yes, if nobody is stopping you, if you are not confident, ask for a CT that, but your report should be that this is in keeping with the stone. I want to confirm it with a CT scan. In head and neck, please remember, in clinical practice also, we use both MR and CT in so many cases, and here there is uh, no, should I say, you can ask the same if you want. What is the pathogenesis of abscess formation in the case of dural venous sinus thrombosis? Now, I think what has happened is that this case is a neglected case, has come to the hospital, all sinuses are gone. I think the patient must be suffering, but because he is alcoholic, nobody is giving him any weightage. So there was a venous infarct, and infarctions at times can the blood products can degenerate into abscess. Why was it in this particular case? I have no idea. Was the patient immunocompromised as if secondary drug abuse, etc.? I have no idea. But but this case, there was a secondary abscess. Cялography, no, cялography is a sort of an invasive investigation, and very few people have got now the skills to do cялography. Nobody, you should not advise it because even to find a duct and to cannulate the duct, at times is a huge problem. You've got the diagnosis. If you if you want to confirm the stone, ask for a CT. That's it. Net, from your 2B world, it will be CT. CT will be better for net. it was not at all a hematoma. This is regarding somebody is saying that can we consider duodenal hematoma? Duodenal hematoma will not enhance. This, the candidate did well, where asked me that I would like to compare it with non-enhanced, and I told the candidate that there was no enhancement. So it was profusely enhancing, as if there is something very vascular. So hematoma will never enhance. Remember that.